Systemic hypertension. Definition: persistent elevation of arterial blood pressure in general more than or equal to 140 over 90 mm mercury or above 130 over 80 mm mercury in patients with diabetes or renal diseases, at least 3 times with some weeks apart, or one reading in addition to one target organ damage, or blood pressure more than 170 over 110. Classification of hypertension: it's divided into several stages with different systolic blood pressure and diastolic blood pressure reading. Optimal: systolic less than 120, diastolic less than 80. Normal: 120 to 130 for systolic, and for diastolic 80 to 85. High normal or pre-hypertension: systolic from 130 to 140, diastolic from 85 to 90. Grade 1 from 140 to 160 systolic, and for diastolic from 90 to 100. Grade 2 more than 160 for systolic, and for diastolic more than 100. Grade 3 more than 180 for systolic and more than 110 for diastolic. Isolated systolic hypertension: systolic pressure is more than 140 while the diastolic pressure is less than 90. Types of hypertension: isolated systolic hypertension or systolic and diastolic hypertension. Isolated systolic hypertension, as we mentioned, systolic blood pressure is more than 140 mm mercury without increase in the diastolic blood pressure. Etiology: atherosclerosis leads to decrease in the aortic compliance, or increased stroke volume leads to hyperdynamic circulation, aortic regurg or PDA. Then systolic and diastolic hypertension, which is due to increase in both systolic and diastolic blood pressure, and this is the true hypertension. We have another classification: primary and secondary hypertension. Primary or essential hypertension: it represents approximately 95% of all cases. It has no known cause. Age of onset: usually at early middle age, more than 35 years old. Positive family history. Predisposing factors are genetic, obesity, stress, salt sensitivity, and smoking. Theories: sympathetic overactivity, activation of the renin system. Increased adrenal gland activity leads to increased aldosterone secretion. Multifactorial theory: stress increases the sympathetic stimulation, leads to renal ischemia, stimulates renin, aldosterone, and increases blood pressure. Hyperinsulinoma due to peripheral insulin resistance. Hyperinsulinemia, due to peripheral insulin resistance. Decreased atrial natriuretic peptide. And finally, baroreceptors resetting. Secondary hypertension. Curable hypertension: it's hypertension with a known underlying cause. It represents approximately 5% of all cases. Secondary hypertension is suspected when the patient has any of the following: age of onset before 25 or after 55 years old, negative family history, rapidly progressive hypertension with early complications. Renal: the details will be in hypertension and kidney. It can be parenchymal or renovascular. Parenchymal is volume-dependent hypertension, glomerulonephritis, diabetic nephropathy, pyelonephritis, polycystic kidney, etc. Mechanism: ineffective disposing sodium, or failure to produce necessary vasodilator substances such as prostaglandins. Renovascular: renal artery stenosis, which by turn activates the renin system. Clinical picture: generalized atherosclerosis and flank bruit. Endocrinal: pituitary and thyroid. Pituitary: acromegaly, endothelial hyperplasia, sodium and water retention. Thyroid: hypothyroidism or hyperthyroidism. Hyperthyroidism leads to isolated systolic hypertension. Parathyroid: hyperparathyroidism. Diabetes mellitus. And for the suprarenal gland: Conn's syndrome, never severe hypertension, muscle weakness and hypokalemia. Cushing syndrome, pheochromocytoma, paroxysmal hypertension. For the CNS: increased intracranial tension, lesions in the medulla, vascular system, polyarteritis nodosa, polycythemia, and coarctation of the aorta. Iatrogenic: contraceptive pills, cortisone, catecholamines, calcium, cyclosporin, immunodepressant drug. Clinical picture: symptoms: asymptomatic in most cases. It may be discovered accidentally. Headache after information. Headache is usually occipital. Blurring of vision, tinnitus, epistaxis, nausea and vomiting. Complications of hypertension may be the first presentation. Signs: examination. Blood pressure: we have persistent elevation more than or equal to 140 over 90 mm mercury and above 130 over 80 mm mercury in patients with diabetes or renal disease, at least 3 times with some weeks apart, or one reading in addition to one target organ damage, or blood pressure exceeding or equals to 170 over 110. It should be measured in both arms. Significant difference may suggest aortic dissection. Signs suggesting secondary hypertension: auscultation of abdominal murmurs, renal vascular hypertension, auscultation of precordial or chest murmurs, aortic disease, palpitation of enlarged kidneys, polycystic kidney, features of Cushing syndrome. Signs of complications: organ failure, ophthalmoscopic examination, presence of new retinal hemorrhages, exudates, papilledema. It suggests hypertensive retinopathy. Neurological examinations: motor sensory defects, signs of lateralization. Cardiac examination: jugular venous distension, gallop, crepitations, and peripheral edema. Peripheral arteries: absence, reduction, or asymmetry of pulse. Auscultation of systemic hypertension, accentuated S2, closed splitting S2, S4, ejection click, ejection systolic murmur due to relative aortic stenosis, or early diastolic murmur due to relative aortic regurg. Resistant hypertension: it's defined as persistent elevation of blood pressure in spite of use of triple antihypertensive drugs, including diuretics, for more than 2 months. Hypertensive urgency: rise of blood pressure rapidly, more than 220 over 120 mm mercury, not associated with target organ damage, such as renal failure, heart failure, stroke. Hypertensive emergency: rapid rise of blood pressure, more than 220 over 120 mm mercury, associated with target organ damage. Accelerated hypertension, hypertensive crisis with grade 3 retinopathy, accelerated or grade 3 retinopathy, and there is a mnemonic accelerated X3. I'm sorry for this, I'm not responsible for this. Malignant hypertension, hypertensive crisis with grade 4 retinopathy plus papilledema. Complications: cardiac, left-sided heart failure due to pressure overload, ischemic heart disease due to atherosclerosis and hypertrophy, Bernheim effect, signs of right-sided heart failure, hypertrophy of the left ventricle may cause bulging in the septum of the right ventricle, leading to slight impairment of the filling in the right ventricle, leads to signs of right-sided heart failure. Cerebral atherosclerosis, cerebral stroke, ischemia or hemorrhagic stroke, hypertensive encephalopathy. As a result of acute rise in the blood pressure, the cerebral blood vessels are no longer able to maintain necessary degree of constriction, failure of autoregulation, and they begin to dilate, increasing cerebral blood flow, increasing intracranial tension, brain edema, coma, and convulsions may occur. How to differentiate between stroke and hypertensive encephalopathy? Stroke: signs of lateralization, unilateral. Hypertensive encephalopathy: no signs of lateralization because it's bilateral. Renal failure, hematuria, proteinuria. Retinal: 4 grades, grade 1, 2, 3, 4. 1. Thickening of the retinal arterioles, silver wire appearance. 2. Kinking of the retinal veins. 3. Hemorrhage and exudates. 4. Papilledema. Vascular: atherosclerosis, aortic dissection. Investigations: routine tests, CBC, plasma glucose, serum cholesterol, uric acid, potassium, creatinine. Investigations for complications: cardiac, X-ray, ECG, echo, cerebral, CT, MRI, brain, renal, urine analysis, renal function, renal imaging. Investigations for the cause: when secondary hypertension is suspected or in a case of refractory hypertension, measurement of renin, aldosterone, catecholamines, adrenal ultrasound, brain MRI. And finally, we have the treatment. Target blood pressure is lower than 140 over 90 mm mercury unless the patient has diabetes or renal disease, in which case the target should be lower than 130 over 80 mm mercury. Lines of treatment: non-pharmacological, lifestyle modifications, and pharmacological. Pharmacological: treatment of associated risk factors such as hyperlipidemia, treatment of the cause in case of secondary hypertension, and finally antihypertensive drugs. Choice of treatment. Lines of treatment: non-pharmacological, lifestyle modifications, loss of weight if overweight, reduce salt intake, high potassium and calcium intake, reduce dietary fat intake, stop smoking, regular exercise, avoid stressful conditions as much as possible, such as meditation. Value: it may normalize the blood pressure in pre-hypertension or in mild cases without any drug, facilitates blood pressure control by antihypertensive drugs, and control of risk factors. Antihypertensive drugs: they are divided into diuretics, sympathetic blockers, vasodilators, calcium channel blockers, angiotensin converting enzyme inhibitors, ACE inhibitors, and ARBs, angiotensin 2 receptor blockers. So, at first we're going to start with the diuretics, but we're not going to start as a regimen. We're going to start by explanation. Diuretics, types, action, side effects. We refer to heart failure as explained. Thiazide is most commonly used in the treatment of hypertension. Lasix is not routinely used in stable cases of hypertension. Indipamide, thiazide analog, which has dilator effect with minimal diuretic effect. Potassium-sparing diuretic is often used with thiazides, such as aldactazide or modiuretic. Sympathetic blockers, centrally acting, ganglion blockers, and finally nerve-ending blockers. Centrally acting, such as clonidine, its action by stimulation of alpha-2 adrenergic receptors, which are sympathoinhibitors. Side effects are dry mouth, postural hypotension, rebound hypertension with sudden withdrawal, ganglion blockers, trimethophan, nerve-ending blockers, alpha-methyl-dopa and reserpine. Alpha-methyl-dopa, it decreases the synthesis of catecholamines with central inhibiting action. Side effects, postural hypotension, hepatitis, and hemolysis. Reserpine, it decreases the reuptake of catecholamines. Side effects are depression, nasal congestion, and hypertonia. Alpha blockers, prazosin, action, vasodilatation. Side effects, first dose syncope and tachycardia. Beta blockers, the mechanism of action still questionable. It decreases contractility, decreasing heart rate, decreasing cardiac output, and it also decreases renin release. Preparations, propranolol, non-selective beta blocker, atenolol, metoprolol, bisoprolol. They are selective beta-1 blockers. Carvedilol, labetalol are combined beta and alpha blockers. Beta blockers with vasodilatation. Side effects for the lung, bronchospasm, for heart, bradycardia and heart block, depression and impotence. Cardiovascular system uses of beta blockers, hypertension, angina, heart failure, arrhythmia, phallus and mitral valve prolapse. Vasodilators, they are classified into arterial, venous, and both. Arterial, hydralazine, minoxidil, diazoxide. Venous, nitrates, both ACE inhibitors and sodium nitroprusside. Hydralazine, it's used in hypertensive encephalopathy by infusion. Side effects are precipitation of angina, lupus-like syndrome, and reflex tachycardia, which is almost always administered in combination with beta blockers. Minoxidil, it's not used anymore, but the side effects are hypertrichosis and the same as hydralazine. Diazoxide, from 100 to 300 mg IV rapidly in hypertensive encephalopathy. Side effects are hyperglycemia. It's only one side effect, hyperglycemia. Sodium nitroprusside, used in hypertensive encephalopathy from 0.5 to 2 microgram per kilo per minute infusion. Side effects, cyanide toxicity. The antidote is sodium thiosulfate. Calcium channel blockers, they were explained in angina. ACE inhibitors, these drugs inhibit the angiotensin converting enzyme which converts angiotensin 1 into angiotensin 2. They also diminish the rate of bradykinin and inactivation. So decreased angiotensin 2 leads to vasodilatation and decrease in the secretion of aldosterone, decreasing in sodium and water retention. Decreased bradykinin inactivation leads to increased bradykinin, which is a vasodilator. We have short-acting and long-acting. Short-acting, such as captopril, from half to 2 tablets 3 times per day. Long-acting, 1 tablet per day, enalapril, lisinopril, and ramipril. Side effects are dry cough, hyperkalemia, skin rash, and first dose phenomenon. Angiotensin 2 receptor blockers, losartan, valsartan, and irbesartan, they are similar to ACE inhibitors but without cough. Choice of treatment. Non-pharmacological measures, lifestyle modification should be initiated in all hypertensive patients and those with pre-hypertension. Selection of specific antihypertensive drugs should take into consideration comorbid conditions associated with hypertension as well as the patient's personal response and financial ability. Uncomplicated hypertension. Stepped antihypertensive therapy. The treatment passes in steps, and if there is not adequate response, we go to the next step. So step 1, initiate therapy with one of the following: ABCD, ACE inhibitors, beta blockers, calcium channel blockers, or diuretics. Step 2, combination of 2 drugs of step 1 including a diuretic. Step 3, combination of 3 drugs of step 1 including a diuretic. And finally, step 4, add alpha blocker or hydralazine to step 3. The use of lower doses of 2 or more drugs may lower blood pressure with fewer adverse effects than the use of a higher dose of a single agent. Treatment of hypertension was certain concomitant diseases. Hypertension was heart failure. Use ACE inhibitors, diuretics. Avoid calcium channel blockers. Hypertension was ischemic heart diseases. Use beta blockers or calcium channel blockers. Avoid hydralazine. Hypertension and diabetes mellitus. Use ACE inhibitors, calcium channel blockers. Avoid beta blockers because they mask the warning signs of the hypoglycemic coma. Hypertension with renal impairment. Use beta blockers, calcium channel blockers, diuretics, alpha-methyl dopa, ACE inhibitors with monitoring creatinine level. Avoid ACE inhibitors in bilateral renal stenosis. Hypertension with asthma or COPD. Avoid beta blockers. Hypertension with pregnancy. Use alpha-methyl dopa, calcium channel blocker, hydralazine or labetalol. Avoid ACE inhibitors, beta blockers, and diuretics. Hypertension with hyperthyroidism. Use beta blockers. Hypertension with peripheral vascular disease. Use calcium channel blockers, alpha blockers, and avoid beta blockers. Hypertensive crisis. It's unwise to lower blood pressure too quickly because this leads to organ hypoperfusion and stroke. Avoid initial reduction in blood pressure more than 25%, or remember that the patient with chronic hypertension may not tolerate normal blood pressure. So lower blood pressure gradually and not more than 25%. The initial goal of the therapy should be to achieve diastolic blood pressure from 100 to 110 mm mercury. In hypertensive emergencies with total organ damage, blood pressure control should be within 1 hour to decrease the risk of permanent damage. In hypertensive urgency, blood pressure control is more slowly over days, not hours. Approach to the patient with hypertensive emergencies. History of hypertension or other significant diseases, medication use, and the history should focus on the presence of target organ damage. Cardiac chest pain may indicate myocardial infarction, shortness of breath. It may suggest pulmonary edema. Back pain may denote aortic dissection. Renal hematuria, decreased urine volume. CNS, nausea, vomiting, visual changes, seizures. Examination, see signs of systemic hypertension, and investigations, see investigations of systemic hypertension. Treatment, rapid-acting antihypertensive drugs, sodium nitroprusside 0.5 to 2 microgram per kilo per minute infusion, nitroglycerin 10 to 100 microgram per kilo per minute, diazoxide 100 to 300 milligram rapidly IV, nicardipine, calcium channel blocker 5 to 15 milligram per hour infusion, hydralazine 20 milligram IV, labetalol 20 milligram IV every 10 minutes until control of blood pressure. Phenoldopam is a new dopamine receptor agonist. Lasix may be used with one of the above agents. Never use sublingual nifedipine to reduce blood pressure in hypertensive emergencies because this can cause unpredictable drop in blood pressure and stroke. Specific treatment, hypertensive encephalopathy, anticonvulsant, diazepam IV, cerebral dehydrating measures, 25% mannitol infusion with Lasix, labetalol, nicardipine, esmolol are the preferred medications. Cerebral stroke, the preferred medications are labetalol and nicardipine. Withhold antihypertensive medications unless the systolic blood pressure is more than 220 mm mercury or the diastolic blood pressure is more than 120 mm mercury in cases of ischemic stroke. Acute coronary syndrome. For acute coronary syndrome, beta blockers, nicardipine, nitroglycerin are the preferred drugs. Note that the thrombolytics are contraindicated if the blood pressure is more than 185 over 100 mm mercury. Acute heart failure, treat with vasodilators in addition to diuretics. Aortic dissection, esmolol, labetalol, sodium nitroprusside. Preeclampsia and eclampsia of pregnancy, hydralazine, labetalol, nicardipine. Malignant hypertension, labetalol, nicardipine, nitroprusside, and enalapril. Hypokalemic hypertension occurs in Conn's, Cushing syndromes, renal artery stenosis, and finally iatrogenic due to diuretics. Hypertension and kidney. Hypertension leads to kidney damage and kidney damage leads to hypertension. Effect of hypertension on the kidney. Hypertension leads to atherosclerotic changes in the renal arteries, narrowing of the arterial lumen, renal ischemia, and nephrosclerotic changes for the glomeruli, glomerular sclerosis, tubules, tubular atrophy, interstitium, interstitial fibrosis, and finally leads to renal failure. Criteria of diagnosis of hypertensive end-stage renal failure, duration or hypertension more than 10 years before the onset of renal failure except in malignant and accelerated hypertension, hypertension before the onset of proteinuria, proteinuria less than 2 grams per day, ultrasound, no evidence of renal disease, and finally presence of left ventricular hypertrophy. Renal disease as a cause of hypertension. We have the parenchymal causes and the renovascular hypertension. So renal parenchymal hypertension ranges depending upon the stage and the nature of chronic renal diseases. Most of renal diseases are complicated by hypertension, but there are exceptions. With chronic pyelonephritis, they have salt wasting, high frequency from 80 to 90% in end-stage renal disease. In acute renal diseases, acute post-streptococcal glomerulonephritis, it occurs by 80%. And then we have pathogenesis, salt retention, the most important mechanism due to decreased GFR by decreased nephron mass and activation of the RAS system. Renal ischemia caused by inflammation and fibrotic changes in small intrarenal vessels, occlusion of intrarenal vessels by renal cyst, or by scar in reflux nephropathy and analgesic nephropathy, stimulation of sympathetic nervous system, failure to inactivate circulating vasoconstrictor substances, and failure to produce vasodilator substances such as bradykinin and prostaglandins. Treatment: controlling blood pressure slows the progression of renal parenchymal diseases. Target blood pressure 130 over 80 mm mercury in patients without proteinuria and 125 over 75 mm mercury in patients with proteinuria. Renal vascular hypertension, renal artery stenosis. Hypertension caused by the occlusion of one or both renal arteries or their branches. Generally, RAS or renal artery stenosis accounts for less than or equal to 5% of secondary hypertensive patients. The frequency increased to 75% in elderly patients with severe hypertension and high creatinine in the serum. Causes: the most common two causes are 95 of all causes, atherosclerosis and fibromuscular dysplasia. Atherosclerosis, the most common cause of renal artery stenosis. Male to female ratio 2 to 1, age more than 60 years, usually unilateral, maybe bilateral, involves the proximal part of the renal artery near the junction of renal artery with the aorta, associated with other atherosclerotic vascular damage such as coronary. Fibromuscular dysplasia, common in young women, starts unilateral, then bilateral, frequently bilaterally, involves the distal 2/3 of the renal artery. Dysplasia, distal, I'm not responsible for this. Multifocal beaded appearance. Total artery occlusion is less common than in atherosclerosis. Other vessel involvement, such as cerebral vessels. Rare causes 5%, extrinsic compression, vasculitis, dissecting aorta, neurofibromatosis, embolism, and congenital anomalies. Pathogenesis, significant arterial narrowing, more than 70% of the lumen, leads to renal ischemia, activation of the RAS system, vasoconstriction, and salt retention, and finally, rise of the blood pressure. Diagnosis, clinical diagnosis: age, young female, less than 25 years, fibromuscular dysplasia; old male, more than 60 years, atherosclerotic renal artery stenosis. Hypertension, recent onset, accelerated or malignant, recently worsened of previously controlled hypertension, or resistant to triple therapy including diuretics. Deterioration of kidney function during treatment with ACE inhibitors. Recurrent episodes of pulmonary edema, flash pulmonary edema, suggest bilateral renal artery stenosis. Epigastric or flank bruit, especially diastolic. Laboratory diagnosis: renal function early in the course of the disease, normal. Hypokalemia and alkalosis due to activation of the RAS system. Renal activity, high, but normal values doesn't exclude RAS. Renal artery stenosis. Captopril stimulation test measures the plasma renin activity before and 1 hour after giving captopril, 25 to 50 milligram, increase of plasma renin activity more than 5.7 nanogram per milliliter per hour indicates positive test. Renal radiology, ultrasound, asymmetric kidney size, 1.5 centimeter difference, IVP, delayed and persistent nephrogram in affected site plus unilateral small kidney. Renal CT and renal MR angiography, the gold standard for diagnosis. Treatment: medical, beta blockers, ACE inhibitors, ARBs. Both ACE inhibitors and ARBs are not allowed in cases of bilateral renal artery stenosis, severe hyperkalemia, or more than 30% increase in creatinine level. Renal angioplasty, stenting, renal artery bypass surgery, renal end arterectomy, removing the fats, cholesterol, and other substances from the renal artery. Nephrectomy for small non-functioning kidney. Choice of treatment depends on the age, elderly, medical, or bypass. For young females, angioplasty. Severe hypertension or renal impairment, surgery. Comorbid conditions, coronary, cerebrovascular, medical, and pathology, atherosclerosis surgery, fibromuscular dysplasia, angioplasty. Cardiorenal syndrome classification, General definition: it's a pathophysiological disorder of the heart and kidneys. Acute or chronic dysfunction in one organ may induce acute or chronic dysfunction in the other organ. CRS type 1, acute cardiorenal syndrome, abrupt worsening of the cardiac function, acute cardiogenic shock, or acutely decompensated congestive heart failure leading to acute kidney injury. CRS type 2, chronic cardiorenal syndrome, chronic abnormalities in cardiac function, such as chronic congestive heart failure, causing progressive and potentially permanent chronic kidney disease. CRS type 3, acute renocardiac syndrome, abrupt worsening of the renal function, acute kidney ischemia or glomerulonephritis, causing acute cardiac disorders such as heart failure, arrhythmia, and ischemia. CRS type 4, chronic renocardiac syndrome, chronic kidney disease, chronic glomerular or interstitial disease, contributing to decreased cardiac function, cardiac hypertrophy. CRS type 5, secondary cardiorenal syndrome, systemic condition, diabetes mellitus sepsis, causing both cardiac or renal dysfunction. And this concludes the cardiology book.